Hello and welcome. I am Yvette Cabasa, Pediatric Reimbursement Education Specialist for the Healthy Steps National Office. Thank you for taking the time today to join us for our second segment of the review of the California Healthy Steps Billing and Coding Guide, where the psychotherapy section of the guide will be examined in detail. As explained in the first segment of the guide's review, the presentation of the guide's entire contents is divided into four segments. In the first segment, we embarked on a journey filled with navigating through coding, billing, and documentation requirements for Healthy Steps aligned services by traveling on the California Billing and Coding Guide's information highway, where the journey ended with the review of smoking and tobacco use cessation. For this segment, segment two, we will continue in our travels and learn about the psychotherapy services open for reimbursement under your state Medicaid agency, Medi-Cal. The third segment provides a review of coding and billing for services that fall under the Comprehensive Perinatal Service Program, including lactation services when provided outside of the program. And the final segment, segment four, will review the new dyadic benefit and the community health worker benefit. Upon the conclusion of this segment, you will walk away knowing the different types of psychotherapy sessions available for Medi-Cal reimbursement, the different categories of patient medical necessity for psychotherapy sessions, the current procedural terminology codes, otherwise known as CPT codes or billing codes, that correspond to the services, the professional licenses eligible for reimbursement, and applicable Medi-Cal billing, coding, and documentation guidelines. Because the Healthy Steps National Office wants to assist in supporting your billing efforts for Healthy Steps aligned services, my goal today is to deliver a clear interpretation of the information provided in the psychotherapy services section of the guide, as this information will help your practice maximize revenue for the delivery of these services. So without further delay, fasten your seatbelts and let us resume our journey on the information highway as we travel on Psychotherapy Road. To begin our journey today, I will review the relevant guidelines that are applicable to the eligible billing providers, including those that require clinical supervision, the different kinds of psychotherapy session types with their corresponding CPT codes, otherwise known as their billing codes, and their applicable guidelines, and the four distinct categories of patient medical necessity approved by Medi-Cal that will support the reimbursement of services. Additionally, I will review the kinds of psychotherapy session types that are reimbursed under each category of medical necessity and the similarities and differences between the different types of categories with an overview of coding, billing, and documentation guidelines for all services. So as you can see, we have a lot to cover. So let's not hesitate. Let's hop into our learning vehicles, buckle up, and pull out of our parking spaces and head down Psychotherapy Road, where the first stop will be the mental and/or behavioral health providers recognized to render psychotherapy services. Medi-Cal recognizes the following providers as eligible providers to render psychotherapy: licensed clinical psychologists, psychologist assistants under clinical supervision, licensed marriage and family therapists, associate marriage and family therapists under clinical supervision, licensed clinical social workers, associate clinical social workers under clinical supervision, licensed professional clinical counselors, associate professional clinical counselors under clinical supervision, psychiatrists, and psychiatric physician assistants and psychiatric nurse practitioners under clinical supervision. But prior to rendering services, it is also important to know the providers that are eligible to receive reimbursement at your clinic type. Associate and assistant mental and/or behavioral health providers are not always recognized for reimbursement at rural health centers known as RHCs and federally qualified health centers known as FQHCs. Also, licensed professional clinical counselors and licensed marriage and family therapists are not always recognized for Medi-Cal reimbursement at these practice types, and verification with insurance carriers and/or your billing department should be made on if these providers are eligible for reimbursement at your clinic. For those sites that are eligible for insurance carrier reimbursement for psychotherapy sessions rendered by associate and assistant mental and/or behavioral health providers, it is important to know that these providers are unable to independently bill for their services, and must work under clinical supervision where the billing is done under the supervising provider. With this said, there are applicable guidelines that come with the clinical supervision of associate and assistant mental and/or behavioral health providers. Let's review them quickly. Associate and assistant mental and/or behavioral health providers are only approved to render psychotherapy services at those clinic types where their services are recognized for reimbursement. The psychotherapy services rendered require direct clinical supervision by a licensed mental and/or behavioral health provider. Guidelines provided by the California Board of Behavioral Sciences tell us that direct supervision is defined as face-to-face contact between the supervisor and supervisee, where weekly face-to-face contact is required within the same week as the hours claimed. The methods in which face-to-face contact occurs between the supervisor and supervisee were not clearly defined, so I recommend verifying with Medi-Cal and other insurance carriers your site participates with on the approved methods and how the face-to-face contact can occur. For more information and additional guidance on supervising associate and assistant mental and/or behavioral health providers, we offer a web link located in the very beginning of the billing and coding guide found in the applicable guidelines section that will further aid in your understanding of direct clinical supervision requirements. Now that we have reviewed the providers eligible for the reimbursement of psychotherapy services with their applicable guidelines highlighted, let us continue in our travels to the second stop on this journey, where I will review the different types of psychotherapy sessions recognized for Medi-Cal reimbursement. And to follow will be the 4 distinct categories of patient medical necessity that are recognized for Medi-Cal reimbursement. Psychotherapy services, also simply known as psychotherapy or therapy, are divided by psychotherapy session types. Medi-Cal recognizes and reimburses for individual, family, group, and psychotherapy sessions for patients in crisis. The guidelines I will review regarding each of these session types will always remain the same, but there may be slight differences depending upon the reason why the patient is receiving psychotherapy, otherwise known as the patient's medical necessity. But I will be sure to highlight those differences as I review the different categories of patient medical necessity recognized for reimbursement. With that said, let us begin with a review of individual psychotherapy. Individual psychotherapy sessions are rendered to patients individually and directly, even if a family member is present at the time of the service. Individual therapy services are only to be related to the patient's diagnosis, where treatment is geared for the patient. The diagnosis of family members, as well as any family dynamics, are not applicable in individual therapy sessions. Individual sessions are commonly rendered to adults and older children. There are 3 CPT codes recognized by Medi-Cal for reimbursement. The first, 90832, is for the reporting of 30 minutes of individual psychotherapy. The second, 90834, is for the reporting of 45 minutes of individual sessions. And the last, 90837, is utilized to report 60 minutes of individual sessions. You may be asking yourself, how would you or could you report less than 30 minutes of an individual psychotherapy session? And the answer, although derived from coding guidelines that were retrieved from the current Optum 360 CPT manual and the American Psychological Association, must be verified with Medi-Cal and other insurance carriers you are contracted with, as insurance carriers hold the deciding factor on the coding and billing guidelines they will recognize, adopt, and apply to their reimbursement for services. Coding books and many online resources, such as those provided by the American Psychological Association, advise of the ability to use what is commonly known as the CPT time rule or the midpoint rule. The CPT time rule for billing psychotherapy sessions provides a time frame for each medical billing code that is less than the time indicated in their descriptions. According to this time rule, 90832, which again is indicated for 30 minutes of individual psychotherapy, can be reported for sessions that run between 16 and 37 minutes. And 90834, which is indicated for 45 minutes of individual therapy, can be reported for sessions lasting from 38 to 52 minutes. And 90837, which is indicated to be for 60-minute individual sessions, can be reported for sessions with a duration of 53 minutes or longer. Before I continue, I will again caveat how verification on the use of this CPT time rule must be made with Medi-Cal and all other insurance carriers your site participates with, as its validation will depend on each insurance carrier's decision to either adopt the CPT time rule or not. Medi-Cal's guidance did not offer confirmation on their adoption of this rule when rendering these services. So again, please be sure to verify with Medi-Cal prior to billing for psychotherapy using the time guidelines under the CPT time rule. Moving forward, let us now review the second type of psychotherapy session, which is family psychotherapy, either with or without the patient present. Different from individual therapy, family psychotherapy not only focuses on the patient's mental or behavioral health, but it also focuses on its effect on the family, where treatment is not only geared for the patient, but also on the effects it has on the family and on family dynamics. During these family therapy sessions, family dynamics as they relate to the patient's mental status and or behavior should be the focus of the session, where attention should be given to the impact the condition has on the family and the patient, with therapy aimed at improving interactions between the patient and family members and or caregivers. When rendering family psychotherapy sessions when a patient is not diagnosed with a mental or behavioral health condition, this may change slightly, as there will not be a condition, but rather a risk factor that is deemed to place the patient at risk of a future mental and or behavioral health diagnosis. During those family therapy sessions, attention will be placed on the risk factors or factors where family dynamics as they relate to the factor or factors will be the focus of the session. This will be reviewed more in detail when we cover the distinct categories of patient medical necessity recognized for the reimbursement of psychotherapy services. There are two CPT codes that represent family therapy. The first, 90847, is for the reporting of 50 minutes of family psychotherapy when the patient is present. And the second, 90846, is reported when the patient is not present during the session. Certain clinic types, such as RHCs and FQHCs, may not be approved for the reimbursement of services when the patient is not present. Therefore, verification with insurance carriers for these clinic types is highly recommended. To bill for family psychotherapy, there must be at least two family members present during the family therapy session, and verification on if one of the two members can be the patient themselves must be made with Medi-Cal, as other insurance carriers and Medi-Cal did not provide specificity for the identification of what would constitute the two family member requirement. When we reviewed the descriptions of the two service codes for family therapy, would you say they have something in common with the descriptions for the service codes for individual therapy? If you say yes and noticed that the descriptions in each billing code contain an allotted time for the service, you are correct. And with recognizing this, you may be questioning if the CPT time rule visited when we reviewed individual therapy applies to the reporting of family therapy. And unfortunately, it may not, as there is no indication in Medi-Cal's guidance that the CPT time rule can be applied when reporting and billing for family therapy sessions. Because Medi-Cal did not provide specified directions on if they adopted the time rule for any of the psychotherapy session types, my direction will be the same as I provided when reviewing individual therapy, which is to verify with Medi-Cal, as well as with other insurance carriers your practice has contracted with, on if they have adopted the time rule for these services or not. If the time rule was indeed adopted and recognized, the rule states that if 26 minutes or more of family psychotherapy is rendered, you can compliantly bill for both of the family psychotherapy codes. Fortunately, Medi-Cal guidelines did convey that they will provide reimbursement for a maximum of 50 minutes per therapy session per day when the patient is not present for the session, and a maximum of 110 minutes per session per day when the patient is present. Additionally, if billing for family therapy under an infant because the diagnosis pertains to the infant, but the infant does not yet have a Medi-Cal number, reimbursement will still be provided if the sessions are billed with the birthing parent's Medi-Cal ID number, but only for the month of the patient's birth and the following month. Medi-Cal guidelines also provide us with the recognized clinical approaches to delivering family therapy, which are child-parent psychotherapy for ages 0 through 5, parent-child interactive therapy for ages 2 through 12, and cognitive behavioral couples therapy for adults receiving marriage and family therapy. Child-parent psychotherapy and parent-child interactive therapy should be aimed at improving interactions between the patient and family members or caregivers, where attention can be given to the impact the presenting problem and or risk factors have had on both. Moving on to the third psychotherapy session type recognized for Medi-Cal reimbursement are group sessions. There are two types of group sessions, one for multiple family group therapy and the other for individual group therapy. Let us review them both. Multiple family group sessions billed with CPT code 90849 is for the billing of group services provided to individual patients and their families, where they either share the same or similar issues or conditions. And group therapy sessions billed with CPT code 90853 is for the billing of a group composed of at least 2 individual patients, but not more than 8, where the group composed of individual patients share the same or similar issues or conditions. Group psychotherapy, unlike multiple family group therapy, would not contain family members, as these group sessions are designed for the benefit of the individual patient in a group composed of other individual patients. The descriptions of the CPT codes for group therapy and multiple group therapy do not include a time requirement for the rendering of services, but Medi-Cal advises that group sessions of less than 1.5 hours are not reimbursable. Verification with other insurance carriers is recommended on if they share the same minimum time guideline for the reporting of these services. Certain clinic types, such as RHCs and FQHCs, may not be approved for the reimbursement of group services. Therefore, verification with insurance carriers for these clinic types is highly recommended. This now brings us to the fourth and final type of psychotherapy session recognized for Medi-Cal reimbursement, and it is psychotherapy rendered to patients in crisis. Psychotherapy for crisis is billed with CPT code 90839 and its add-on code 90840. These codes are for the billing of individual therapy sessions where the patient presents to be in crisis, reflecting a high distress disposition. There are clear definitions of a patient in crisis, and according to the American Psychological Association, psychotherapy for crisis is applicable when a patient presents in high distress with a problem or problems that are typically either life-threatening or are so complex that immediate attention to a patient's high distress is required. Common examples given to describe when psychotherapy for crisis is to be rendered is if a patient displays suicidal intent and or when a patient presents with disabling anxiety. There are 2 billing codes approved for Medi-Cal reimbursement for therapy for crisis. The first, 90839, is for the reporting of the first 60 minutes of a therapy session for crisis, and the second, 90840, its add-on code, is for the reporting of each additional 30 minutes of service after the first 60 minutes of its primary code, 90839, has been rendered. Now, for those who have already listened to the first segment of this 4-segmented review of the Billing and Coding Guide for Healthy Steps Aligned Services, you are aware of what an add-on code is. But for those of you who have not yet had the opportunity to listen to segment 1, let me provide a quick recap of that detailed review. Add-on codes are codes that can only be billed in conjunction with other codes. Therefore, they are not independently billable, meaning they cannot be billed by themselves. Add-on codes can be thought of as buddy codes, created to be partnered and billed with the other specified codes they are designed for, which are referred to as primary codes. And in this coding scenario, 90839 would be the primary code, where 90840, its add-on code, can only be billed in conjunction with it. The full description of the billing codes for psychotherapy for crisis sessions include how these are face-to-face services with the patient. But due to the lift in coding and billing guidelines because of the COVID-19 pandemic, verification with insurance carriers should be made on if psychotherapy for crisis can be rendered via a telehealth modality. And speaking of the description of these CPT codes, you may be questioning how would you or could you report a crisis session that lasts less than 60 minutes? My response will be the exact same response I provided when we reviewed individual and family psychotherapy, where Medi-Cal did not specify that the CPT time rule was adopted for use. Insurance carrier verification is required and if this time rule is recognized when reporting and billing for therapy for crisis services. If the time rule has been adopted and approved for use by an insurance carrier, then crisis sessions can be billed for sessions that are between 30 and 74 minutes, where if additional time is rendered, its add-on code 90840 can also be billed. But again, please do not apply this rule when selecting and billing for crisis sessions without first verifying with Medi-Cal and other insurance carriers and if they have recognized and adopted the rule. This concludes my review of the different types of psychotherapy sessions approved for Medi-Cal reimbursement, which now brings us to the review of the different types of categories of patient medical necessity recognized to support the patient and or family's need for therapy sessions. During this review, I will supply you with all of the categories of medical necessity recognized for Medi-Cal reimbursement, as well as the different types of psychotherapy sessions that can be rendered under each category. I will also provide you with their applicable guidelines, including the minimal documentation requirements for each session type. Medi-Cal's revamping of their Medicaid policies geared in improving young children's developmental health, social and emotional health, and supportive dietic care has resulted in expanded categories of patient medical necessity that will support the reimbursement of psychotherapy services. Currently, this expansion has provided 4 categories of medical necessity approved for Medi-Cal's reimbursement for therapy sessions. The 4 categories are patients diagnosed with a mental health or a developmental disorder of infancy and early childhood, patients who are not diagnosed with the disorder, but either they or their parent or legal guardian present with one of the approved risk factors that have been deemed to place the patient and or the parent or legal guardian at risk of a future mental or behavioral health diagnosis. The third category is for patients who present with persistent mental health symptoms in the absence of a mental health diagnosis. And last but definitely not least, the fourth category is for patients who are at risk of perinatal depression and present with one of the approved risk factors that are deemed to place them at risk for depression. Let's take a closer look at these categories of medical necessity. The first, psychotherapy services for treatment of mental health disorders or developmental disorders of infancy and early childhood, is recognized for Medi-Cal reimbursement for therapy sessions for patients of any age that are diagnosed with either a mental health disorder as defined by the Diagnostic and Statistical Manual of Mental Health Disorders for Adults, or as defined by the Diagnostic Classification of Mental Health and Developmental Disorders of Infancy and Early Childhood. Diagnosis codes are not specified for the billing of psychotherapy sessions under this category of medical necessity because there is a range of different mental health and developmental disorders of infancy and childhood diagnoses to select from. What is specified is to be sure to code for the mental, behavioral, and or developmental disorder diagnosis that pertains to the patient. There are 4 types of therapy sessions available for reimbursement when rendering therapy for a disorder. The first are individual therapy sessions, billed with CPT code 90832, 90834, and 90837. The second are family psychotherapy sessions, with or without the patient, billed with CPT codes 90846 or 90847. The third session type are sessions that involve groups, and there are 2. The first, group sessions, billed with CPT code 90854, are for the reporting of group therapy sessions of group composed of patients only. And the second, family group sessions, billed with CPT code 90849, are for the reporting of therapy sessions composed of groups of patients and their families. And for the fourth of the psychotherapy session types approved for Medi-Cal reimbursement for the treatment of a mental health disorder or developmental disorder of infancy and early childhood is psychotherapy for crisis. Therapy for crisis is billed with CPT code 90839 and its add-on code 90840. And as a reminder about psychotherapy for crisis, this service is for the reporting of individual therapy sessions where the patient presents to be in crisis, reflecting a high distress disposition, such as when a patient presents in high distress with a problem or problems that are typically either life-threatening or are so complex that immediate attention to the patient's high distress is required. The minimal documentation requirements for psychotherapy sessions provided to a patient with a disorder include a signed and dated treatment plan. Treatment plans are important for mental health care as they provide a guide to how services may be best delivered. They act as a map for the therapeutic process and provide the patient and the therapist with a way of measuring if therapy is working. A treatment plan for when patients are diagnosed with a disorder should include the patient's personal information, such as demographics and psychological history, the patient's mental or developmental disorder diagnosis, and a general outline of the patient's prescribed and treatment goals. It also should include measurable objectives, a timeline for treatment progress, space for tracking progress, and the number of therapy sessions ordered by the patient's primary care physician, as this is a requirement when psychotherapy is rendered in the primary care setting. In addition to patient's treatment plans, documentation should also include the patient's symptoms and functional status and a mental status examination. It should also include the prognosis, progress, and if not included in the treatment plan, documentation on how the patient is or has not benefited from therapy in reaching goals. And last but definitely not least, the time spent rendering the psychotherapy session to the patient and or the patient and family. Notice how I was specific when I said the time spent rendering the psychotherapy session and not the time spent with the patient or the duration of the visit. I was very specific for a very good reason. When documenting time for a time based service, which is any service that includes time in the description of their CPT code, you must only calculate and include the time spent rendering the actual service you are billing for. And it must not include the entire time spent with the patient and or on additional services rendered to the patient, even if they are related. Related services, such as the reviewing of records, communication with other providers and family members, and the time utilized on medical decision making, are examples of services that cannot be calculated into the time spent rendering psychotherapy. Only the duration of the time spent providing the actual therapy session is to be calculated for the selection of the time based psychotherapy billing code to report. These additional related services are bundled into the psychotherapy time based codes. Therefore, they are integrated into the code. We're billing for them separately or separately calculating them into the time for the service is not allowed. When documenting for family therapy services, in addition to these minimal documentation requirements, your documentation must also include how the patient and family is or has benefited from therapy and reaching goals, family communication and dynamics, either verbal or nonverbal, as they relate to the patient's mental status and or behavior. Also, the impact the condition has on the family and the patient, and if coding for family psychotherapy without the patient present, documentation stating that the patient was not present for the session and why the patient was not present should be in the note. When documenting for group services, in addition to these minimum documentation requirements I just reviewed, your documentation should also include documentation of the group services in each patient's medical record with a start and stop time of the group session and the primary focus of the session. Also, the patient's diagnosis should be included in the documentation with a summarization of the clinical intervention used and personal and group dynamics and how the participants share the same or similar conditions or issues. The only difference between the documentation requirements for group psychotherapy and multifamily group psychotherapy is how, when rendering group psychotherapy, you must also include whether the individual patient participated and how they participated in the group session. And when rendering multiple family group psychotherapy, you must not only include if and how the patient participated, but if and how the family members participated in the group session. Let us now take a look at the documentation requirements for reporting therapy sessions when the patient is in crisis. These sessions must include how and why the patient presented in a crisis state, where the clinical judgment of the clinician was used to reach the decision that immediate attention was required. A preliminary assessment of risk, mobilization of resources used to diffuse the crisis and restore safety, the psychotherapeutic interventions used to minimize emotional trauma, and the outcome of the session is also required in the documentation. With concern to frequency limitations placed on the number of sessions that Medi-Cal will provide reimbursement for, verification should be made with Medi-Cal and other insurance carriers on the number of sessions that are eligible for reimbursement, as it can vary when a patient is diagnosed with a mental or developmental disorder, where the insurance carrier may reimburse for a certain number of sessions without prior insurance authorization and may or may not reimburse for additional sessions if a prior authorization is obtained. The second category of medical necessity recognized to support psychotherapy services is psychotherapy when a patient is not diagnosed with a mental health disorder or a developmental disorder of infancy and early childhood. Like psychotherapy services provided to patients that are diagnosed with a disorder, Medi-Cal also recognizes and provides reimbursement for therapy services provided to patients without a concrete mental health and/or a developmental disorder of infancy and early childhood. In 2021, Medi-Cal updated its Medicaid non-specialty mental health services manual to clarify eligibility for psychotherapy benefits, which include the addition of when a patient was not diagnosed with a mental or developmental disorder. Rendering and billing for therapy in the absence of a concrete mental and/or developmental condition can be provided to patients that are under the age of 21 when either they or their parents or guardians present with a history of or a current risk factor that is deemed to place them at risk for a mental health disorder. Specific regulations were appended to this added covered psychotherapy benefit, with the most significant regarding the required presence of risk factors, where a set of recognized risk factors are compiled to define and support the reimbursement for psychotherapy. The set of risk factors are divided into two lists. One list is applicable to the child, and the other list is applicable to the parents or guardians. There are 9 risk factors listed for each, and Medi-Cal guidelines advise that only one must be present, either in the parent or the child. Let's take a look at these risk factors. First, let us review the risk factors applicable to patients who are under the age of 21 that have a history of at least one of the risk factors listed. The first risk factor is if the child has a history of neonatal or pediatric intensive care unit hospitalization. The second is if the child was separated from a parent or guardian due to incarceration, immigration, or military deployment. The third is if there was a death of a parent or guardian. The fourth is foster home placement. The fifth is if there is food insecurity and/or housing instability. The sixth is if a child has exposure to domestic violence. The seventh is if there is a history of maltreatment. The eighth is if the child has a history of severe and persistent bullying. And the ninth is if the child has experienced discrimination based on race, ethnicity, gender identity, sexual orientation, religion, learning differences, or disabilities. The second list contains the risk factors applicable to a child who has a parent or guardian with at least one of the approved risk factors. So let's review those now. The first risk factor is if the child's parent or guardian has a serious illness or disability. The second is if the child's parent or guardian has a history of incarceration. The third is if the child has a parent or guardian that has suffered with depression or is suffering with depression or other mood disorders. The fourth is if the child has a parent or guardian that suffers with post-traumatic stress disorder or other anxiety disorders. The fifth is if the child's parent or guardian has a psychotic disorder and he or she is under treatment. The sixth is if the parent or guardian has a substance use disorder. The seventh is if the child's parent or guardian has lost their job. The eighth is if the parent or guardian has a history of intimate partner violence or interpersonal violence. And the ninth is if the child's parent is a teen parent. Now that I have reviewed both sets of risk factors, let us proceed with the psychotherapy session types that are approved for reimbursement under this category of medical necessity. Individual therapy, billed with CPT codes 90832, 90834, and 90837. Family therapy, with or without the patient present, billed with CPT codes 90846 or 90847, and multiple family group sessions, billed with CPT code 90849, are approved for Medi-Cal reimbursement. Guidelines on rendering therapy sessions under any of the medical necessity categories, including this one, do not change, but there may be slight differences in the diagnosis and the minimal documentation requirements. Let's review those diagnosis requirements and minimal documentation requirements that did change for when a patient is not diagnosed with a disorder. For therapy sessions provided to patients under the age of 21 who are not diagnosed with a mental or developmental disorder, but either they or their parent or guardian present with one of the approved risk factors, Medi-Cal has approved the reporting of diagnosis code Z71.89 to support the medical necessity for psychotherapy services rendered under this category of medical necessity. The description for this billing code is Other Specified Counseling, and this diagnosis code should be present on all claims submitted. Now, with regard to any differences in the minimal documentation requirements for each therapy session type, all requirements remain the same. But again, there are a few differences, and here's a quick highlight of them. Previously, I reviewed the minimal documentation requirements for individual therapy sessions and advised that the documentation must include the patient's mental or developmental disorder. But when rendering psychotherapy to a patient that does not have a mental or developmental diagnosis, but rather they or their parents or guardians present with at least one of the Medi-Cal approved risk factors that deem to place them at risk of a mental health diagnosis, you would document the risk factor or factors where identification would be made on if the factor or factor are those of the patient or of the parent or of the legal guardian. Also noted should be how the risk factor or factors are or can have impact on the patient. Regarding the information provided in my previous review of minimal documentation requirements for family sessions, I highlighted that not only does the patient's condition need to be present in the documentation, but that the documentation should include the impact the patient's condition is having on the patient and/or the family. Well, when documenting for a family session rendered to a patient without a condition, but when they or their parent or legal guardian present with a risk factor or factors, the documentation would then change to reflect the impact the risk factor or factors is having on the parent and the patient and the family as a whole. Where if the risk factor or factors are that of the parent or guardian, then attention can be placed on those risk factors, where services can be rendered to the parent or guardian or to the parent or guardian and patient combined. And this is compliant as long as the parents or guardian's risk factors are having a direct impact on the patient. Also, family dynamics observed during the session should be in your documentation. For multiple group sessions, the same minimal requirements previously reviewed are also applicable, but instead of documentation of the shared condition and issues or of the similar condition and issues shared between the patients and their family, the documentation must now reflect what are the same or similar risk factors shared between the patients and families. This brings us to the end of the differences found within the minimal documentation requirements for each psychotherapy session type. When rendered to patients that are not diagnosed with a mental health or a developmental disorder of infancy and childhood, but either they or their parents or guardians present with one of the approved risk factors. To end our review of this category of medical necessity, let us examine if Medi-Cal has placed frequency limitations on the number of sessions they will provide reimbursement for. And because Medi-Cal guidelines did not specify that there is a limitation placed on the number of sessions that can be provided to patients, it is believed that these sessions are unlimited. But I highly recommend that verification with Medi-Cal and other insurance carriers be made on if they will indeed provide reimbursement for an unlimited number of psychotherapy sessions. This brings us to the third category of medical necessity, recognized to support psychotherapy services, which is psychotherapy when a mental health diagnosis is suspected. As seen when providing therapy services to patients that are diagnosed with a disorder and to patients that are not diagnosed with a disorder, but either they or their parent or guardian present with one of the approved risk factors, Medi-Cal will also provide reimbursement for psychotherapy services when a patient presents with persistent mental health symptoms in the absence of a mental health diagnosis. Persistent mental health symptoms can potentially be an indication of a mental health disorder or the potential of developing one. And Medi-Cal will provide reimbursement for psychotherapy for patients under the age of 21 who have not been diagnosed with a mental health disorder, but do present with persistent mental health symptoms. And for those patients 21 years of age and over, they will reimburse for up to 6 individual psychotherapy sessions per year. The approved therapy session types under this category of medical necessity are individual, family, multiple family groups, and therapy for patients in crisis. All previously reviewed guidelines for these session types are applicable when billing for patients that fall under this category of medical necessity, with a few differences found in the diagnosis that supports medical necessity for these sessions and slight variations in minimal documentation requirements. And here's a highlight of those differences. As seen with therapy sessions provided to a patient that is under 21 years of age, not diagnosed with a mental or developmental disorder, and or either they or their parent or guardian present with one of the approved risk factors, Medicare has also approved the reporting of diagnosis code Z71.89 to support medical necessity for individual, family, multiple family groups, and psychotherapy for crisis sessions for patients who present with persistent mental health symptoms in the absence of a mental health diagnosis. The description of code Z71.89 again is other specified counseling, and this diagnosis code should be present on all claims. With regard to the differences in minimal documentation requirements for each psychotherapy session type, again, all requirements remain the same with one difference. Let us review that one difference now. Remember how when documenting for sessions for patients diagnosed with a condition or disorder, the patient's diagnosis was required? And remember how the documentation of a patient or parent or guardian's risk factor or factor is required when documenting for a patient or parent or guardian who does not have a condition or disorder? Well, when documenting for a patient who presents with persistent mental health symptoms in the absence of a mental health diagnosis, you would document the patient's persistent mental health symptoms and include their functional status and or mental status. With that said, I am sure you can see a pattern in why and how there are slight differences in minimal documentation requirements under each category of medical necessity. The pattern reflects the same throughout, that for each category of medical necessity, what is documented for should be tailored to support the description of the medical necessity category. For example, when a patient has a mental health diagnosis or a developmental disorder of infancy and childhood, the documentation calls for the identification of that diagnosis. But if the patient does not have a disorder, but rather he or she or their parent or guardian presents with one of the risk factors recognized to support medical necessity for therapy, then the documentation alters, in that instead of the diagnosis being documented, the clinician would document the risk factor or factors and identify if it is that of the patient and or of the parent or guardian. With understanding this pattern of change for minimal documentation requirements for psychotherapy provided under each category of patient medical necessity, you will never lose sight of how most of the minimal documentation requirements stay the same, with the exception of what needs to be altered due to the medical necessity category your patient falls under, and how your care and documentation will revolve around this. With regard to the slight changes for each therapy session type for patients that present with persistent mental health symptoms in the absence of a mental health diagnosis, documentation should define the persistent mental health symptoms with a history of when they started, why and how they started, if known, and any other pertinent information regarding the patient's persistent mental health symptoms. But slight changes can be seen in the minimal documentation requirements when rendering multiple group sessions under this category of medical necessity. All requirements remain the same, except for how previously documenting the patient's condition or risk factors, you would now document the persistent mental health symptoms being experienced and shared by the patients participating in the multi group session, as well as how they are affecting the patients and their families. Regarding the frequency limitations placed on the number of therapy sessions that Medi-Cal will provide reimbursement for, Verification should be made with Medi-Cal and other insurance carriers your site participates with on the number of sessions that are eligible for reimbursement, as Medi-Cal guidelines do not specify frequency limitations on the number of sessions they will provide reimbursement for under this category of medical necessity. The last of the four categories of patient medical necessity recognized to support the reimbursement of psychotherapy sessions is psychotherapy for the prevention of perinatal depression. Medi-Cal will also provide reimbursement for psychotherapy for patients that are at risk of perinatal depression, whose guidelines affect the requirement of the need for the presence of at least one of the five risk factors that have been approved to identify patients that are at risk for perinatal depression. Let us take a look at these five risk factors, where Medi-Cal guidelines tell us that only one out of the five is needed to support medical necessity for psychotherapy services. The first is if the patient has a history of depression. The second is if the patient has current depressive symptoms that do not reach a diagnostic threshold. The third is if there are certain socioeconomic risk factors present, such as if the pregnant or postpartum patient is an adolescent and or if they are a single parent and or if the patient has a low income. The fifth is if the patient has recently experienced intimate partner violence. And the last of the risk factors deemed to place the patient at risk for perinatal depression is if the patient has mental health related factors, such as elevated anxiety symptoms or a history of significant negative life events. Medi-Cal's guidance was not specific on what is considered to be a significant life event, so it is recommended to verify with Medi-Cal and or other carriers on what they identify as a significant life event. Medi-Cal will reimburse for two types of therapy sessions when rendering psychotherapy to patients that are deemed to be at risk for perinatal depression. The first are individual therapy sessions, and the second are group psychotherapy sessions. The diagnosis code series recognized when billing for psychotherapy sessions for the prevention of perinatal depression are those associated with an encounter for the supervision of a normal pregnancy, or that for a routine postpartum follow-up visit. The Z34.9 series of ICD-10 codes, otherwise known as diagnosis codes, are used to report an encounter for the supervision of a normal pregnancy. This Z34.9 series of codes are codes based on trimesters of pregnancy and should be selected according to the trimester the patient is in during the time of the visit. The last digit in these codes, the fifth digit, will represent the trimester the patient is in on the date of service. And when reporting the diagnosis for a routine postpartum follow-up visit, Z39.2 would be the diagnosis code to utilize. The billing under this category of medical necessity is unique from the other categories of medical necessity because it requires the reporting of a billing modifier, regardless of which psychotherapy session type is being rendered. This modifier is used to identify that the psychotherapy session being rendered is for the prevention of perinatal depression. I am referring to modifier 33. Modifier 33 is the required modifier that must be appended to either CPT code 90832, 90834, 90837, or CPT code 90853 when billing for the prevention of perinatal depression. The description of this modifier is preventive service, and Medi-Cal guidelines state it is required when billing for psychotherapy sessions for the prevention of perinatal depression. Minimal documentation requirements for therapy sessions approved under this category of medical necessity remain the same, remembering that the documentation should be tailored to the category of medical necessity your patient falls under, which means that for this category, the documentation must include any of the five approved risk factors that will reflect what the preventive psychotherapy sessions will be tailored for. Regarding the frequency limitations placed on the number of sessions that Medi-Cal will provide reimbursement for, Medi-Cal will reimburse for 20 sessions of either individual psychotherapy or group psychotherapy, or a combination of both individual and group sessions to pregnant and postpartum women of any age, delivered during the prenatal period and or during the 12 months following childbirth, who are deemed to be at risk for perinatal depression. remembering that when billing for these therapy sessions, modifier 33 must be appended to the billing code on the claim. And this, fellow travelers, brings us to our third stop on Psychotherapy Road, where I will review 5 additional billing and coding nuances, either not previously reviewed or not reviewed in detail, and are relative to the successful reporting of psychotherapy services. To start, I will head with a shared guideline that is required for all session types under all categories of medical necessity. And this is when rendering psychotherapy services to patients in the primary care setting, it is the responsibility of the primary care physician to refer the patient to the mental and or behavioral health provider approved to deliver the psychotherapy service. The primary care physician should also provide the number of therapy sessions to initially be rendered upon making the referral. A good idea to ensure insurance carrier reimbursement is to be aware of the maximum number of therapy sessions they will reimburse for when billing in the primary care setting. This number can vary. So, for those categories of patient medical necessity where Medi-Cal guidelines did provide information on frequency limitation, please be sure to verify the number of therapy sessions approved. The second guideline, that is a shared guideline among all therapy session types, is how Medi-Cal does not provide reimbursement for psychiatric diagnostic evaluations when the same mental health and or behavioral health provider is billing for a psychotherapy session on the same data service. Because psychotherapy services include the evaluation of a patient's functional and mental status, billing for a psychiatric diagnostic evaluation on the same data service would be something referred to as double dipping. The term double dipping, when used to describe an incident in medical billing, is when a provider bills for 2 different billing codes on the same data service, where one of those billing codes also includes the services for the other code being billed for. The third guideline, that is also a shared guideline, but not a shared guideline for all psychotherapy session types, but rather a shared guideline for all categories of medical necessity, is that when rendering psychotherapy due to a patient being in crisis, no other psychotherapy session or service will be reimbursed for on the same data service. The fourth guideline I will review refers to an add on psychotherapy billing code used to report prolonged psychotherapy sessions. The reporting of this service code is not approved to be billed with all psychotherapy session codes, but only by those approved with Medi-Cal and other insurance carriers. Billing code 99354, whose description is prolonged physician services requiring direct patient contact for 1 hour beyond the usual service, is reported when psychotherapy services were provided for 1 hour beyond the usual psychotherapy service time, which is that being the time indicated in the description of the therapy billing code you are reporting. Medi-Cal recognizes billing code 90837, which is for the billing of a 60-minute individual therapy session, and billing code 90847, which is for the billing for a patient present 50-minute family psychotherapy session, as those psychotherapy services eligible to be billed with the prolonged service code. But these 2 psychotherapy sessions are not approved to be rendered under all categories of medical necessity. 99354, prolonged psychotherapy, can be billed with CPT code 90837 or CPT code 90847 when billed for patients diagnosed with a mental health diagnosis or a developmental disorder of infancy and early childhood, and can also be billed for patients not diagnosed, but either they or their parent or guardian present with one of the approved risk factors that deem them at risk of a mental health diagnosis. Additionally, prolonged psychotherapy can also be billed for a patient who presents with persistent mental health symptoms in the absence of a mental health diagnosis, but it may not be billed for patients receiving therapy services for the prevention of perinatal depression. Let us take a look on how you would code and bill for prolonged psychotherapy services when pairing it with the 2 therapy session type recognized it to be billed and paired with, otherwise referred to as its primary codes. The description for CPT code 99354 again reads prolonged psychotherapy service requiring direct patient contact provided for 1 hour beyond the usual service time. And for a clear understanding of what this description means when it relates to how and when the code is used, I will take a step-by-step method approach to interpret the description. The first step is to identify that the code is for the reporting of the first hour of additional time taken to render the service in the designated primary code, which again would be either 90837 or 90847. The second step is to understand what this means. Reporting of the first hour of additional time taken to render the service in its primary code or codes signifies that CPT code 99354, when billed with 90837 or 90847, would be for the billing of 1 hour beyond the time indicated in the description for each of these codes. Therefore, when pairing with 90837, you are indicating that you are billing for the initial 60 minutes of individual psychotherapy services plus an additional hour of service. And when pairing with 90847, you are indicating that you are billing for the initial patient present 15-minute family psychotherapy session plus an additional hour of service. But what if I told you that the CPT time rule can be applied to the billing for prolonged psychotherapy services? You remember the CPT time rule, correct? It's the rule that allows a time based code to be billed for less than the time indicated in its billing code's description. Do you also remember that Medi-Cal guidance does not include specificity on the approval for using the time rule when billing for any of the psychotherapy sessions? Therefore, verification with Medi-Cal and other insurance carriers your site participates with is a must. Well, for the billing of the prolonged service code 99354, Medi-Cal guidance does specify that the CPT time rule can indeed be applied. What do you think this means regarding the time requirement for the compliant billing of prolonged psychotherapy services? If you guessed it would change it, you guessed correctly. To understand this change, you would first need to know Medi-Cal's new time requirement for the reporting of billing code 99354 when applying the CPT time rule. Medi-Cal's new time requirement when applying the CPT time rule for the billing code 99354 advises that instead of reporting 99354 for each additional hour of prolonged services, you would instead bill for prolonged psychotherapy for each additional 30 minutes of service. Let's take a closer look at what this would mean by utilizing one of the approved billing codes that prolonged services can be paired with, 90847. When billing 90847, which again is for the billing code for a 50-minute patient present family psychotherapy session, with billing code 99354, which is for the billing code for the prolonged psychotherapy service, you are billing for 80 minutes of family psychotherapy when the patient is present. How did I reach that conclusion? Well, let us take a quick look at the number of minutes for each billing code being reported. If reporting 90847, which again is for a 50 minutes, again for 50 minutes of service, and also reporting prolonged psychotherapy service code 99354, which again is for 30 additional minutes of service when applying the CPT time rule, then you are adding 30 minutes to the already 50-minute family psychotherapy session being billed, therefore billing for 80 minutes of that service. Again, Medi-Cal's guidelines indicate that because the CPT time rule is applicable for this 1 hour prolonged service code, it can instead be reported when an additional 30 minutes of services are rendered. To further your understanding of the CPT time rule and how it applies to the reporting of prolonged psychotherapy services, we provided a web page link in the applicable guidelines column located in the psychotherapy table found in the psychotherapy section of the guide. Once you click onto the link, you can locate the information on page 5. There you will find the information on how Medi-Cal has adopted the CPT time rule for the reporting of prolonged services, and it includes their calculation of the time requirements. Upon utilizing this web link, you will notice that the prolonged service code is indicated for use with other codes, but with reference to psychotherapy services, Medi-Cal will only reimburse for the additional time rendering prolonged psychotherapy services when applied to the 60-minute individual therapy code and the 50-minute patient present family psychotherapy code. Additionally, you will also notice that another prolonged service code, 99355, is similarly recognized for Medi-Cal reimbursement, But Medi-Cal psychotherapy guidelines advise that the only prolonged service code recognized as an add-on code when billing for 60 minutes of individual therapy or when billing for a 50-minute patient-present family psychotherapy session is CPT code 99354. The fifth and last additional guideline I will review today are those guidelines that pertain to interactive complexity billed with CPT code 90785. 90785 is an add-on code, meaning that it cannot be billed on its own, but rather in conjunction with another code or codes that it is approved to be paired with. This add-on code is a unique add-on service if compared with the others related to Healthy Steps aligned services and how it is not a time-based code. This indicates that the time utilized to render this add-on service is irrelevant to its billing. Interactive complexity is reported when specific communication difficulties were present during a visit that complicated the delivery of care of the primary service rendered. Interactive complexity is not considered a separate service, but a service that represents added complexity in delivering another, and its code can only be reported as an add on code for psychiatric diagnostic evaluations and psychotherapy services where family psychotherapy and psychotherapy for crisis are not included, which is why I am revisiting this add on service during this segment of the guide. A detailed review of interactive complexity was provided in segment 1 of the Billing and Coding Guide. Before a recap, I will highlight some of the guidelines. Guidelines for compliantly reporting interactive complexity include a list of communication factors recognized as those that can additionally increase the intensity of the primary service rendered. And of the list of factors, only one needs to be present during the encounter to compliantly bill for interactive complexity. Let's take a moment to review these communication factors as they are quite specific. The first factor is if there is a need to manage maladaptive communication related to high anxiety, reactivity, repeated questions, or disagreements among participants that complicated the delivery of care. The second factor is when caregiver emotions or behaviors interfere with implementation of the treatment plan. The third is if reporting to a third party is required due to an incident in the patient's life that may have caused psychological damage, but the incident must be newly discovered during the visit. Example of incidents are abuse, either physical or psychological, and neglect. And last on the list of those communication factors recognized to additionally increase the intensity of services is when using play equipment or other physical devices for patients who either have not developed or have lost either expressive language communication skills to explain their symptoms and respond to treatment, or for patients who lack receptive communication skills to understand the provider when they use typical language or communication. Those professionals that can render and bill for the add on code for interactive complexity are licensed clinical psychologists, licensed marriage and family therapists, licensed professional clinical counselors, licensed clinical social workers, psychiatrists, psychiatric physician assistants, and psychiatric nurse practitioners. Remembering that not all clinicians may be eligible for reimbursement at your clinic type, such as seen at FUHCs and RHCs. Prior to 2022, the use of interpreters and translator services were included in the list of communication factors that support the medical necessity for the reporting of interactive complexity. But to align with federal and the Center of Medicaid and Medicare Services, this was removed from the list of communication factors. And this, fellow travelers, brings us to the end of our review of psychotherapy services. And because we covered so much detailed information regarding the billing and coding for psychotherapy, and because I understand how information can get lost in translation when reviewing a plethora of information at a given time, I'd like to end our travels on Psychotherapy Road by concluding with a summary of the information covered today so that we can piece the puzzle of all of its elements of information together. We started on a brisk ride through the identification of the mental and or behavioral health providers recognized to furnish psychotherapy services with applicable guidelines, which included a review of what is clinical supervision. Also reviewed was the importance of knowing which of these approved providers are eligible to render services at your clinic type, as FQHCs and RHCs may not be eligible to receive insurance carrier reimbursement for services rendered by associate and assistant mental and/or behavioral health providers, as well as those rendered by licensed marriage and family therapists. Following the review of this information, I shared the psychotherapy session types with their corresponding CPT codes that are otherwise referred to as billing codes. In this area of review, I also included their applicable guidelines. And for a quick recap, Medi-Cal will reimburse for individual psychotherapy for 30, 45, and 60-minute sessions, as well as 50-minute family therapy sessions for when the patient is or isn't present at the session. Medi-Cal will also reimburse for two types of group sessions. The first, referred to as a group session, is for a group of at least two individual patients and up to 8 individual patients who share the same or similar conditions or symptoms or risk factors. And the second, referred to as multiple family group sessions, are for a group of at least two patients and their families, where the patients and families share either the same or similar conditions, symptoms, or risk factors. Also reviewed were psychotherapy sessions for patients who are in crisis, which are sessions for individual patients who present with a high level of distress with a complex or life threatening problem that requires immediate attention. To follow, we reviewed the 4 distinct categories of patient medical necessity approved for Medi-Cal reimbursement, which are psychotherapy when a patient is diagnosed with a mental health diagnosis or a developmental disorder of infancy and childhood, therapy when a patient is not diagnosed with a disorder, but either they or a parent or guardian present with one of the approved risk factors that deem them at risk for a future mental health diagnosis. Also, therapy when a patient presents with persistent mental health symptoms in the absence of a mental health diagnosis, and therapy for the prevention of perinatal depression. Additionally, included in this section for review, I discussed the psychotherapy session types approved to be rendered under each category of medical necessity, with its coding, billing, and minimal documentation guidelines, including any differences found within each category of medical necessity. To follow, we also learned if there were frequency limitations placed on the number of therapy sessions that are approved for Medi-Cal reimbursement, as well as any additional guidelines not previously reviewed during the segment. By knowing the clinicians that can render psychotherapy services, the categories of patient medical necessity that are eligible for Medi-Cal reimbursement, including the psychotherapy session types that can be rendered under each category of medical necessity, and by knowing coding, billing, and minimal documentation guidelines that fall under each category of medical necessity, as well as for each psychotherapy session, you are fully equipped with the tools your site needs to bill Medi-Cal and receive reimbursement for psychotherapy services. And now, fellow travelers, we have reached our exit off of the psychotherapy road, which ends the second segment of the Healthy Steps National Office presentation of the California Coding and Billing Guide. I hope you've enjoyed this journey designed to provide insight on coding and billing for psychotherapy services. I have enjoyed compiling this information for you and presenting it to further support in your understanding of the many different nuances encountered when coding and billing for insurance carrier reimbursement. Now, although this brings today's presentation to a close, I'd like to remind you that this isn't the end of our travels, as there are 2 additional segments left to complete the review of the Coding and Billing Guide. Segment 1 provided a review of all Healthy Steps aligned services in the guide, up until smoking and tobacco use cessation counseling. This segment, Segment 2, provided a review of the psychotherapy section in the guide. Segment 3 provides a review of the comprehensive perinatal service program, including lactation services when provided outside of the program. And the final segment, Segment 4, will review the new dyadic benefit and the community health worker benefit. Thank you so much for your interest in not only billing and coding for Healthy Steps aligned services, but for rendering these services, as together we can achieve improved outcomes for young children and families. Together, we bring focus to the important interwoven skills needed for families to foster healthy child development and lifelong well being. and we must stand proud as we help transform the promise of pediatric primary care by promoting nurturing parenting and healthy development for babies and toddlers. Until our next journey, thank you for your attention, your time, and the opportunity to present to you today. Goodbye, all.